Toronto Rehab Institute, and with a clinical focus in acquired brain injury, stroke, and spasticity. She holds a full-time clinical academic appointment as a clinician teacher in the Department of Medicine at the University of Toronto, serving as an assistant professor. She completed her residency in physical medicine and rehab at the University of Toronto. She also completed her master's degree in system leadership and innovation from the University of Toronto's Institute of Health Policy, Management, and Evaluation. Dr. McIntyre has a special interest in virtual care and education, including harnessing technology to improve access to specialist care in underserved communities. She has worked on distant education projects across Ontario, as well as in rural areas of Uganda and Nepal. So with her background and her specialization, I'm very pleased to welcome you, Michaela, and ask you to take us through your presentation.
Okay, thank you so much, Eileen, Tina, Stefan, for having me this afternoon, and very nice to be with you all. So as mentioned, today we're talking about recovery trajectory in the young stroke patient. So I'm hoping that by the end of this presentation, we will have talked about the prognosis for recovery of young stroke patients, and we'll talk about some differences when comparing to the general population. And we're also going to talk about how the recovery trajectory can alter the rehabilitation journey and some focuses for rehab in this population. Not much to disclose. As mentioned, I do work at Toronto Rehab, and I am on the board of a charity called Nepalability. I run their education program, but there's no relationship to the material presented today and no financial disclosures. So who is young? I know this can be, it can really depend on who you ask. I know some of my colleagues who work in the pediatric population would say that this definition is not what they would say, but for the purpose of our talk, because I understand most of the audience is working with adults, we're looking at patients 18 to 60 years old. And in some studies, they'll use a cutoff of 45 years old, but the most common would be anyone who's younger than 60. And why are we having this talk? Well, as I'm going to show you in the next slide, actually cases of young strokes are on the rise over time. And we know that the survival rates are high, but that these patients have longer lives to live with some degree of disability. And they'll ask you a lot of questions, including why did this happen? Is it going to happen again? And what's the rest of my life going to look like? So here's just one study that was looking at the proportion of strokes aged 20 to 50, and they showed that from 1993 to 2005, the rates increased from 13 to 19%, which is actually pretty significant. And up to 15% of all strokes occur in young patients. It's actually quite a lot. And just in terms of global, as I have a personal global interest, the majority of strokes that are in young and middle-aged patients do occur in low and middle income nations, but we do see a lot of these patients globally. So I wanted to ask you, we've got just 2 polls in this session. So the first one is here. And what proportion of patients in your clinical practice are of this age range we're talking about, of the 18 to 65, whether it's anywhere from less than 25% to more than 75%. So thank you so much. So the poll has been launched. So please take a moment to vote. It's anonymous. I won't see your names, but it just helps to get a bit of context for who's in the virtual room today.
And Michaela, I'll just mention while we're waiting for the poll, there was one comment in the Q&A, if we could turn up the volume a little bit. I've personally, it's working fine for me, but that was just in the Q&A.
Oh, okay. I'll try to speak a little louder if I can. I know I have a loud booming voice, so I hope it's not too loud, but I'll definitely try to make sure I'm speaking loudly. Thank you.
Thank you.
Yeah. And Eileen or Tina, when you see enough responses, then you can go ahead and end the poll. I'm not able to see how many have rolled in, but hopefully you're out there polling away.
Yeah, we're just short of 100.
Awesome. Okay. yeah, so you may be able to, hopefully you're able to see the results. So it looks like, yeah, good mix. So almost half of you see about 25 to 50% of young stroke patients. That's actually a lot. 5% is more than 75%. And then there's about 40% that's less than 25%, and 8% that's 50 to 75. So really the majority of you actually do see quite a number of young stroke patients. So that's really interesting, and sets a lot of helpful context for what we'll be talking about, because we will go through a case, but I think you all will probably have a lot of clinical experience and cases to reflect on as well. So I know that this series started off on causes of stroke for the young adult. So we're not going to go into a lot of detail today, but just to remind ourselves that there can be ischemic causes as well as hemorrhagic causes. And some of them are similar to the general population, but there is a focus on, whether it could be pharmacotherapy, genetic conditions, arterial disease, or especially in the hemorrhagic cases, arteriovenous malformations or ruptured aneurysms. And as you're working with these patients, they may really ask you, what can I do to try to make sure this does not happen again? So I also just wanted to quickly touch on not only the non-modifiable risk factors for stroke that people may have. That could include, family history, a previous stroke, congenital defects in their heart, or conditions like atrial fibrillation, or being in the pregnancy or postpartum state, but that there are a lot of modifiable risk factors that relate to kind of nutrition, lifestyle, as well as managing some risk factors like diabetes and hypertension. Okay, so let's get into our case. So this is a real case. This is a 24-year-old woman who was previously healthy and fully independent, who was working both as a server and as an early childhood educator, educated to the diploma level, no substance use, living with her mother. She developed a sudden onset severe headache that radiated to the neck. She collapsed and had transient left-sided weakness for 20 minutes that then improved. EMS was called and she was brought to the hospital, where her Glasgow Coma scale was initially 15, so that's normal. And she had neuroimaging, including a CT and CT angiogram that showed intracranial hemorrhage that included subarachnoid hemorrhage. So that's bleeding in the deep space of the brain. That was from a ruptured brain aneurysm, which is damage to a vessel wall that can cause significant bleeding. And she also had mild hydrocephalus, so that's extra cerebrospinal fluid in the brain spaces, as well as vasospasm, so constriction of the blood vessels in the brain. So lots going on in her brain, but the most significant being a ruptured aneurysm causing subarachnoid hemorrhage. So she had urgent coiling of her aneurysm, so that's basically putting metal into that abnormality of the blood vessel wall to try to prevent further bleeding, and insertion of a flow diversion stent, so that's to kind of divert the blood flow away from that area. So just to recap ourselves on subarachnoid hemorrhage, so as I mentioned, that's bleeding in between two membranes surrounding the brain and sort of the deepest levels. That represents 5% of all strokes, but within that category, about half of these cases are 55 years or younger. The classic symptom is what she had. So severe thunderclap headache. That means a headache that's the worst headache of your life that happens within a few seconds. That can be accompanied by neck pain or stiffness, vomiting or decreased level of consciousness, and may also have seizure with onset as well. So the most common causes are, if it's not a traumatic case, would be a ruptured aneurysm or arteriovenous malformation, which means basically an abnormal collection of blood vessels where the arteries and veins meet each other. That can also be prone to bleeding. The diagnosis is either with neuroimaging, or if it's a more subtle case, it may be with lumbar puncture to analyze cerebrospinal fluid. And this is a neurosurgical emergency. So up to 20% of these cases, the person may actually not even survive transport to the hospital. So it's a very serious condition. And the immediate treatment is usually coiling, so putting metal into the blood vessel abnormality to try to stop further bleeding. And then there may be further neurosurgical procedures that are necessary. So let's go back to our case. So later the same evening, right after her neurosurgery, she had decreased level of consciousness And now there was seen a left frontal hematoma, so bleeding in the left frontal lobe that extended to the ventricles, as well as swelling around that area. So that caused something called mass effect, where there was a shift in the midline of the brain to the right, causing also herniation. So that's basically risk of parts of the brain compressing down towards the spinal cord. So that can also be a very life-threatening condition. And so she was urgently intubated. She was started on a couple of medications. So one, Keppres for seizures, and then hypertonic saline, that's to treat the swelling in the brain. And then she had a ventricular drain placed. So basically kind of drilling into the skull and placing a drain to try to relieve some of the excess pressure. The next day, her CT head did show that the bleeding was now stable, but she did have increased brain swelling. So she then went back to the operating room and she had left craniectomy. So that was basically removing a portion of the skull to relieve the pressure. While she was in the hospital, unfortunately, there was still further complications that she had. So I mentioned that initially they saw a little bit of hydrocephalus, but this condition continued to the point that she needed a shunt inserted into the brain to drain the extra cerebrospinal brain fluid. She also had pneumonia. And then if all that wasn't enough, she also had a brain infection requiring intravenous antibiotics for 6 weeks. So now let's fast forward to about 2.5 months after this injury occurred. So now the patient is medically stable. She's still on the antibiotics for her infection. She's participating with the acute care physiotherapy and occupational therapy and speech therapy. So she's doing about 2 to 3 sessions a day, about 30 minutes per session, and her sitting tolerance is more than 2 hours. She needs moderate assistance for upper body dressing, maximum assist for lower body. She needs maximum assist for bathing, moderate assist for toileting, and she needs 2-person assist for transfers and mobilities up to 20 meters with 2 seated rests. Some comments on the rehab application. So she was having impaired recall, but with a lot of repetition, she could carry over and learn. She had attention deficits and she was benefiting from 1 step and reduced distractions. She was having some evidence of apraxia and difficulty with motor planning and benefited from some hand over hand with new tasks. She did have some impulsivity, so she needed a bed alarm and seatbelt alarm. And she had some right-sided inattention, needing some encouragement to incorporate her right upper extremity in tasks. Okay, so back to you. Our second poll question is, how would you triage her applications? So the options are, you could, and this is application for inpatient rehab. So you could decline that she's not ready just yet. You could accept her for inpatient now. You could say not for inpatient, but you could accept for outpatient, or maybe you need more information prior to making a decision.
Okay. I'm going to end the poll in just another second.
The suspense. I feel like I need it.
Yes.
Maybe I should do a drum roll.
Okay, I still am seeing some responses, so I'm waiting, but okay, now I'm going to end it.
Okay. Okay, so it looks like the overwhelming majority would like to accept her for inpatient now. And then there's a couple who said maybe wait a little longer, maybe just plan for outpatient, or some of you need more information. I think there's no kind of set one absolute answer, but I really appreciate everyone's participation, and I will let you know soon what we ended up doing. So thanks so much. So first, let's talk a little bit about recovery and prognosis before we get to what ended up happening, and her story will continue. So when it comes to the young stroke patient, let's start with the good news. So after the initial stroke severity, we know that age is the next most important factor for prognosis. And studies have shown this again and again, that young age is associated with greater neurologic and functional recovery. That age can be inversely related to functional outcome. And here's one example, that the probability of a good outcome in this study decreased by 3 to 4% for each 10-year increase in age up to age 75. And then after age 75 decreased by 10%. So quite a significant drop off after that. And we know that younger patients have better long-term survival. So mortality has been shown to be up around 20% lower in young adults versus older adults. So what about the not so good? So we know that cognitive deficits tend to persist despite young age, and that, you know, when these patients have been studied, that they do have lower scores on cognitive performance tests versus age-matched controls. And 70% of young stroke patients report at least one significant disability in work and social functioning due to cognitive impairments post-stroke. We also know that there's higher rates of anxiety and depression, and that there's higher risk of recurrent stroke, although I will say that that's a little bit conflicting when you look at all of the literature as a whole. And the incidence of stroke recurrence can range from 0.7 up to 19%, depending on the study and depending on the type of stroke. In terms of, you know, as mentioned from the introduction, I also have an interest in health systems. So just touching briefly on the resource impact that, as we mentioned, younger patients are living longer with residual disability. And so the economic benefit of inpatient rehabilitation is quite high. Some studies have indicated that quite a number of weeks of inpatient rehab, even this study showed 21 weeks, would be required in order for the rehab cost to offset the cost of dependency, which we're not always really able to give that length of inpatient rehab, or probably most settings we work in, we're not able to give that level of inpatient rehab. And we know that there's a greater relative benefit from dedicated stroke unit care for younger patients versus elderly stroke patients. And there's less of an effect of the age-related deterioration of cognitive and physical functions. Like we see many patients that are like the one that I presented, where they truly didn't have any background medical history. So to our point about timing, and I think this speaks to what many of you highlighted in the poll, we know that eligible patients should engage in rehab as soon as they can tolerate it. That, you know, both in animal model studies like what I'm showing here, they found that there's, you know, a greater benefit to even the neurologic function like dendritic branching that was seen in unaffected areas, and reorganization of the cortex following ischemic injury if you start rehab early versus like at day 5 versus day 14 or 30. And that in general, there is a sensitive time window for enhancing neuroplasticity after injury when the brain is kind of maximally primed to respond to rehab, which is why we always advocate for such intensive early inpatient rehab. And that, you know, many studies have shown this in terms of better functional outcomes at the 3 to 6 month mark. The one quick caveat I'll just touch on is there was this AVERT trial where they looked at really intensive early mobilization, like the less than 24 hour. And they found that in that case, it was actually better outcomes in the usual care group at 3 months post-stroke than if people were having really intensive, very early mobilization in the first 24 hours. So the kind of conclusion here was that shorter, more frequent early mobilization improves the chance of regaining independence, but higher doses of long-term mobilization could worsen outcomes. So that's just kind of one caveat to keep in mind. So just touching a little bit deeper into recovery after stroke. So we know that there can be spontaneous or intrinsic recovery of neurologic injury with just by virtue of what's happening underneath the skull. So things like resolution of harmful factors like edema, the ischemic penumbra, so that's the area around the ischemia in ischemic strokes that's vulnerable to damage, and local toxins that can be released in acute injury. So that does certainly account for a big chunk of spontaneous recovery in the 3 months, first 3 months. But we also know that there's neuroplasticity that relates to structural and functional reorganization of the central nervous system. And then there can be secondary cortical areas recruited. So that's kind of adjacent areas of the brain trying to kind of assume the functions that were lost during the stroke. And then when we also look at kind of compensatory techniques within neuroplasticity, that talks about kind of functional reorganization of the cortex that can also enhance neurologic recovery. And we know that The recovery of neural impairments and functional independence, as we mentioned, it tends to occur most within the first 3 to 6 months after stroke, but more severe strokes can have a more protracted recovery. The best ADL function tends to be on average after about 13 weeks, and the overall best neurologic recovery tends to be seen after 11 weeks. But in speaking to you all, and especially when we think of our young stroke patients, and in my experience to date, and likely yours as well, we know that our patients can certainly make significant gains after this time. And I think that's kind of one of the take homes of today's session that we're hoping to kind of focus on. I just wanted to touch on a couple motor factors that we can keep in mind that people may ask us about early on. And while we don't always want to give like a very specific answer, and it's helpful to kind of wait and see, often there are some factors that have been studied that may give a glimpse into what we'll expect in the future. So when we look at arm weakness, if someone has complete paralysis, we know that is a poor predictor. And if there's no activation of the upper extremity at 4 weeks, then the studies would indicate that typically this limb will be a helper arm or supportive arm at best. And that if someone has very severe weakness at onset, that the chance of regaining good hand function is about 11%. It's also a poor prognostic sign if there's no grasp at 4 weeks. But if there is a measurable grasp at 4 weeks, then 70% has good recovery within 3 months. We also know that if there's proximal preservation, like shoulder active movement, that's a good sign. And if you see that by 3 months, someone has the ability to flex and extend their fingers, then there is the potential to make further gains for more than a year in specifically practice tasks. So these are kind of pulled from different studies, and I do have some references at the end if you want to delve further into the literature. And then for lower extremity, so we know that if someone is able to self-propel a wheelchair after 1 week after their stroke, then about 97% will be able to walk at discharge. But even if they're not able to kind of meet this milestone, still approximately 62% of stroke patients will be able to walk. And then it's a very good sign if someone's able to activate the muscles around the hip joint within a week. Then it says that ambulation would be possible, but may require an assistive device and or ankle orthosis. And as we've probably seen in our clinical practice, that motor recovery typically starts proximally and then moves distally thereafter, and may occur in a specific sequence that can sometimes be referred to as Brunstrom stages of motor recovery. And there's certainly other scales out there. Brunstrom is just one example. So let's bring it back to our young patients. So as we said, the most powerful predictor of prognosis after stroke is the initial stroke severity, as measured by a standardized functional scale such as the FIM. But age is the next most significant factor. And but we have to keep in mind that the contribution is still somewhat small compared to stroke severity. And it's not considered to be a strong predictor of functional recovery after stroke, but it is still very important for us to keep in mind. A couple other factors. So we tend to see that hemorrhages recover better and more completely than infarct, because we think that there's a smaller actually infarcted territory and that a larger area might be affected early on due to brain swelling and the toxins from the blood being where it is. And we think as the blood gets reabsorbed that there could be more potential to have this big boost of recovery. And then we know that subsequent strokes tend to have a slower and less complete recovery. We think that there may be a set amount of neuroplasticity that each brain has, which is why we focus so much on secondary stroke prevention. And then aphasia and bowel and bladder incontinence are a couple other factors that have been linked to worse prognosis in the literature. So in terms of age, so I know we're not talking about the very elderly, but just to quickly mention that we still want to consider even very elderly patients for rehab, regardless of their stroke severity. Some factors that are important to consider in that population would be their pre-morbid fitness and functioning, their cognition, any comorbidities they have, and their family and community support. And then young patients, as a general rule, do tend to do better with their rehabilitation. and should be considered for inpatient rehabilitation, even when quite severe, as they are frequently discharged home with significant gains made, although may still require support. So in terms of assessing our stroke severity, so as you all know, we recommend to assess with the alpha FIM at day 3 after stroke. And that score can help us to triage into kind of a milder stroke with the early FIM score more than 80 or motor more than 62. The moderate, which is kind of 40 to 80 on the alpha FIM, or 38 to 62 on motor. And severe would be less than 40 or less than 38 on the motor. This can then help us to triage with what rehab stream would be most helpful for our patients. So if the FIM is over 80, then many of these patients can actually just be managed in the outpatient setting. If they're moderate, so that 40 to 80, then these are often very good candidates for inpatient specialized rehab. And if they're severe, so less than 40, then they may not necessarily qualify for rehab or may benefit from a slow stream program. But if young, so that's why I wanted to show you this, like less than 55, or they have caregiver support, then it's still recommended to consider inpatient specialized rehab. In general, we can expect about a 20-point improvement on the FIM after rehabilitation. So that's kind of just across all strokes. And also just to remind ourselves that not all patients need rehab. About 20% of stroke survivors do recover full functional independence by about 2 weeks post-stroke, so may not need any rehab. And another 20% have such severe functional deficits that they are expected to remain non-ambulatory and require assistance with all ADLs, irrespective of rehabilitation efforts. But we're kind of dealing with the middle 60%. Okay, so let's come back to our case. So let's just remind ourselves. So this was our 24-year-old woman who had subarachnoid hemorrhage. She also had large frontal hemorrhagic stroke, and she also had complications, including CSF, a cerebral infection and hydrocephalus needing BP shunt insertion. So she was admitted to inpatient rehab. We accepted her. So that was about 2.5 months after the initial event, and her admission FIM was 52. So some deficits noted at that time. So she had right upper extremity weakness, and she also had significant nausea and vomiting that was limiting her participation. And then she had significant cognitive deficit. So MoCA was completed and she scored 10 out of 30. So kind of points lost across the board in basically all domains. So she was in our inpatient setting for 6 weeks. So any prediction, so her initial FIM was 52. So if we think that we are hoping for about 20-point improvement, that's what we saw. So her discharge FIM was 72. And at the time of discharge, so she had progressed to ambulation with 4-wheeled walker, and she required contact guard assist of 1 person for stairs. She was having some improvement in route finding, but she still needed repetition and she needed a memory binder. And she was continuing to have some difficulty with initiation of tasks and decreased short-term memory. She was discharged home with her mother and home support, and her mother actually took a leave from work to basically be around 24/7, as very frequent supervision was recommended. So when we think about rehabilitation of the young adult stroke survivor, so we know that these patients tend to be employed, they're often driving, they may be caring for dependents, and they may be relying on work-related income. So these are some kind of unique challenges that our older stroke patients may not necessarily have. We also know that they have unique psychosocial and supportive needs. As I mentioned earlier on, the young stroke patient tends to have higher levels of depression and anxiety, and we know that that is linked to worse outcomes when not treated. And you know, it can relate to the fact that this is just such a huge change in the trajectory of the young patient's life and what they had maybe seen for their life initially. It can be a really big adjustment. It can be very difficult. And some of the conventional rehab strategies that we may do for our older patients may not necessarily apply to our younger patients. We know that there should be quite an emphasis on participation in fitness activities that might include kind of more high demand leisure activities. And there are some strategies that you might employ to try to improve motor recovery in the young, like constraint-induced movement therapy, some robot-aided rehab if you have access to these kind of devices, virtual reality, functional electrical stimulation. This is not an exhaustive list, but just a few examples. And then especially when you're looking at the outpatient setting, there's quite a focus on community reintegration, including return to work, return to driving, and family life, and continuing to manage psychosocial issues. So this part is just a little teaser for some of the sessions that are to come. You're actually gonna, if you're able to attend the full series, have dedicated sessions on many of these aspects that I think are gonna, delve into this in much more detail than I could, but just a little bit of an intro. So when we think about return to work, the studies show that return to work rates in young stroke patients are not bad. About just over half may return to full-time employment, but they tend not to return to the same exact employment that they were doing before. In terms of predictors of return to work, so younger age, a higher functional status and lower degree of disability, absence of psychiatric illness, higher education level, absence of apraxia, and white-collar occupations tended to predict higher rates of return to work. And the white-collar occupation, that may speak to the fact that there's kind of higher likelihood of being able to accommodate disability. There may be kind of more optimal work conditions, and these occupations also are often less physically demanding and may have more autonomy associated with them. And some barriers to return to work that have been cited in the literature: aphasia, cognitive deficits are linked to have twice the likelihood of being unable to return to work. And this is where the role of neuropsychological testing, if you have access to this in your center, may help with determining safety and accommodations that may be beneficial. Depression or emotional lability. But we also know that the inability to return to work can lead to significant emotional and financial hardship. So this is a really crucial area to try to work on when people are doing their rehab. And then psychosocial concerns. So we know that stroke events are very consistently acknowledged as being traumatic, and young patients do need time to come to terms with the changes in their physical ability, their work, family, and social roles for sure. Young patients do have an interest in connecting with other young stroke survivors. So this is where sometimes if you work in inpatient, you may be able to kind of make the connection of other patients who are on the unit, or in the outpatient setting, there's often option for connecting with peer support groups. And I think this is something that young stroke patients, at least in my experience, have shown a lot of interest and benefit from, especially when they're on a unit and they may feel like what they're seeing in general doesn't necessarily reflect themselves. And then we talked about the high rates of anxiety and depressive symptoms, where post-stroke depression rates can be as high as 27 or even up to 30% in this population. And then we know that many of our younger patients, as well as older patients, may be sexually active, and that there can be very high rates of sexual impairment in young stroke patients. There's an example study I've shown here with rates quoted of 29%, and that a decrease in sexual activity is very common post-stroke. The barriers can include not only physical impairments, but also psychological factors, including the changes to body image and potential changes in communication. The evidence shows that sexuality and sexual intimacy is something that we should be discussing, ideally during inpatient rehabilitation, to open the discussion, and then addressed again after transition to the community. I know in my rehab setting, especially before COVID, we would have people able to go home for weekend passes before they would be discharged. And that could be a really nice time to start to talk about intimacy and see if the person wanted to kind of try some things and then regroup after the weekend and debrief with their clinicians in terms of how things went and any barriers that we could try to troubleshoot together. Since the pandemic, I know for my setting, it's been a little more difficult to have weekend passes, but we do the best we can to still try to address these topics early and then after transition to the community. And then family stress and caregiver burden is a huge factor to discuss for these young patients. Many may have children, They may be primary caregivers themselves. And there was one study that showed that actually 38% of young stroke survivors had conflict with their spouses, even as early as during inpatient rehabilitation, and that 1 in 7 couples separated within 3 months of the stroke. So I think this is something to really be aware of and flag early when possible. And that caregivers of stroke patients suffer from high rates of depression and deterioration in their own health. So, and especially when the caregiver of a young patient is their spouse, there can be very high rates of emotional distress. And then return to driving. So we know that driving is a significant marker of independence. And when someone is no longer able to drive, it can really significantly impact social activities and well-being. So after a stroke, we recommend that the minimum duration that someone should refrain from driving is 1 month. But depending on their level of impairment or if they had associated seizures, then that duration may be much longer. There was one study I found that showed just over half of stroke patients received a driving assessment, and over 2/3 were able to return to driving. There certainly can be vehicle modifications for stroke-related impairments. And if there's visual field impairment, then they would likely need a specialized vision assessment and a vision waiver. And then also if you have access to things like driving rehab and simulator training programs, then driving fitness can be improved in the young stroke patient. And we also know that some of our patients may impose self-regulations to reduce their driving exposure. So that could be things like not driving at nighttime or avoiding highways or not driving in the winter when conditions are poor. Okay, so let's come back to our case. So I saw her actually not too long ago, and this was now in the outpatient setting about 5 months after discharge from our rehab setting and about 9 months post-event. So at this point, she was now in outpatient rehab. So she'd actually finished her physiotherapy course, but she was continuing with occupational therapy and social work and had been fortunately extended for another month. She was still living with her mother, and her mother was approved for leave from work until the end of the year. So for another about 3 or 4 months. So she was medically stable. So she actually had been able to stop her anti-seizure medication for 3 months and had no evidence of seizures. She'd had follow-up neuroimaging that was all stable. She was still having some occasional headaches, but they were controlled with acetaminophen. Her nausea and vomiting was much better, but still happening 1 or 2 times a month, with triggers most predictably being motion. Her memory, she noticed, was still impaired, but she felt like it was getting better. And her mood, she said, was really good. She said she was really enjoying the kind of simple things in life, and that even an outing such as going to the grocery store with her mother had taken on a new meaning. So that was, I think, really meaningful for me to hear her say. So we talked about her goals. She hoped to return to driving when safe, but wasn't in a tremendous rush. And she was also hoping to return to work. So she felt like she was kind of bored at home, and she was, really craving that return to work, where she both worked as a server and also as an early childhood educator. The latter occupation being what was a bit more important to her. So she had been in touch with the school that she worked at and said they were supportive of graduated return to work when she felt ready. We repeated a different version of the MOCA. And so she improved from 10 when I first met her to 22. So it's big improvement. So she still had a lot of trouble with delayed recall, but she could remember 2 additional words when I gave her the category and 1 additional word with a multiple choice cue. Her trails A and B were actually pretty good. So 37 seconds on the A with no errors, which is in the normal range, and 1 minute and 6 seconds on B, which is also less than the 100 seconds that we'd want to see. And then her physical exam was actually looking great. So she was ambulating with no gait aid, and she stepped out twice when we started doing tandem gait, but then she actually improved with more trials. And the rest of her neurologic exam was actually within normal limits in terms of her cranial nerves, her strength, her sensation, reflexes, and coordination. So in terms of what we talked about in this visit, so I talked to her about the fact that I would expect her to continue to make further gains in function for at least 1 year post-stroke. And then we talked about gradually progressing her duties at home. And that, excuse me, sorry. We discussed that now might actually be the right time for her to start to have a bit more independence at home. and that her mom could start to leave her alone because she was really nervous to do that. But we said we could start with some safety strategies like, not using the stove while alone for now. We also talked about seizure risk and the fact that the highest risk would be in the first 3 months after stopping her anti-seizure medication, but that the risk would further decrease as more time passed. And then we talked about return to driving. And I told her that, things are actually improving really nicely, that her occupational therapist could do more detailed return to driving assessments, but that I suggested that she wait another 3 months, and she wasn't in a big rush anyway, for retesting with me. That would also give her more time off of her anti-seizure medication to make sure there was no seizure recurrence. And then for return to work, I felt like she wasn't quite ready because she was still in outpatient therapy, but she was looking into volunteering, which I really supported. And then she was also hoping to move out. So we talked about just not doing both things at the same time, but rather kind of picking one to focus on first. And that when she wanted to return to work, she had been scheduled for neuropsychological testing, which I thought would be really informative, and that under the guidance of her occupational therapist, she could have a graduated progression of duties and hours to make sure that she would be successful. And then we plan to check in again in 3 months' time. So all is going well. I think this case, why I picked this case is because it highlighted, a very severe initial stroke and someone who, on one hand, it seemed a little bit guarded coming to rehab already pretty much at the 3-month window, when we would say, oh, well, should the most recovery be in kind of the first 3 to 6 months? But we saw that she did still make really nice gains during inpatient rehab. And then the gains she made it from going home and through outpatient, I think really highlighted the potential for these patients to really continue to recover even once they cross the 6-month window. So, in terms of what happens after 1 year, it's hard to say in terms of neuroplasticity, but these patients can even continue to make further functional gains when they continue to be as motivated as someone like she is. So I'm really looking forward to continuing to follow her, and I hope that her case could kind of bring to life some of the principles we talked about, and also break up some of the extensive studies that I posted. So just some kind of concluding points to leave with. Younger age is a good prognostic factor after stroke. And, we should really consider these young patients for rehab, even when they have a severe stroke and a protracted illness course. We know that cognitive deficits tend to persist and patients live longer with their disability. And that these patients do comprise a unique rehab population with particular emphasis on return to work, return to driving, sexuality, and other psychosocial factors, and family stress. And I encourage you, if you can, to attend the subsequent talks that are going to be in this series that are going to delve into those much more. So hopefully today, by the end of this presentation, you now have reviewed prognosis for recovery of young stroke patients, and especially when we compare to the general population. And we've talked about how the recovery trajectory can alter the rehab journey. So I'm so happy to share these slides if they would be helpful for you. And you'll see it's a little hard probably for you to read now, but when you get them on your own computers, if you want to delve into, because I know that there's a lot of specifics in studies that you may wonder, well, what was the exact kind of context? Or, when you just pull one line on a slide, it can sometimes be harder to really use it. So please feel free to delve further into the literature if you're interested. The studies are all here. And I hope I've left, about 10-15 minutes for questions. And I've also shared my email and my Twitter handle, so that if you want to connect outside of this, would be very happy to as well.
So thank you, Dr. McIntyre. And there's some time, and I think some questions are coming in. So please feel free to start adding your questions into the Q&A.
Yeah, I've got the first question, Dr. McIntyre, if I can read it for you. It says here, it sounds like a big part of her success was her family support, i.e. mom being able to take time off work. What would the team have suggested if she didn't have that kind of support at home?
I know. Oh my gosh, what a good question. Because I felt that same way, that I was just so grateful that she had that support network. And if she didn't have that, we would have really had to do, more functional assessments to determine whether she could manage at home with full home and community care support, and kind of maxing out on, not only meal support and PSW if needed, but also just kind of what is she going to do in the times when she's alone, because she had a lot of impulsivity at the time she went home. So I think this is where it can be really challenging, and where sometimes people may not be able to return to independent living at the time, in that time frame if they don't have the support.
From Paula Jane, what is the sensitive period of enhanced neuroplasticity after injury?
Yes, thank you, Paula Jane. So we'd say it's mostly the first 3 to 6 months, and especially the first 3 months is when you're seeing, all of those different mechanisms of neuroplasticity. So, not only in the first kind of 6 weeks is when we'll see a lot of some kind of just resolution of the, swelling or edema, some of those toxins that are in the brain. So that's kind of just one thing. But in terms of the kind of reorganization of the neurons that are happening within the brain, that's kind of happening the most in the first 3 months, but up to the first 6 months.
And next question from Alexi. Often I speak with young stroke clients who are eager to return to work early in their recovery journey. How would you go about having a conversation with the client and encourage them?
I know, Alexi, and I always find this to be tough because when I try to put myself in their shoes, and I know you never really can, but I can only imagine like how much I love my job and how much I would want to be like, no, let me back like immediately. So this can be a tough area for sure. One of the lines that I have found has gotten the most buy-in has been to talk about how after a significant stroke, rehabilitation is actually a full-time job, and that your brain and body trying to recover and rehab from a stroke is absolutely exhausting, and the time and effort that's needed and recommended is more than equivalent to what most of us are doing for our occupations. So that's where we usually try to talk about the fact that for the first up to 12 months after stroke, I'm really recommending to people to focus on their recovery. And then usually I'll try to delve a little bit deeper into like, what is it about the work that's, making them feel that so much that they need to go back. And sometimes it might be like a financial pressure that potentially, applications to their employer may be able to help with, or letters that I can write or that the team can write. So then sometimes we'll try to problem solve with them and encourage them to at least try to wait until they're doing their outpatient rehab to start to look at return to work readiness. But sometimes people will still go for it anyway, I have to say.
And our next question is, how much impact does the external healthcare environment and infrastructure impact stroke recovery in young patients? Should young Canadians living abroad as expats strongly consider relocating back to Canada from a stroke recovery perspective?
Oh, that's interesting. Yeah, I guess it would depend on what has exactly happened for the person and what's available in their context versus what they would be able to have if they relocated back to Canada. I haven't really found myself in this situation, but I have had people who are kind of transiently in Canada or live in Canada plus somewhere else, who are really, really keen to return to another country, like even from discharge from the hospital. And so like I'm often trying to just discuss that, the recovery trajectory is a long journey that most often goes beyond the time that someone's in the hospital. And I'm usually recommending to someone to be somewhere where they can complete an outpatient rehab program prior to moving to another country. So I guess if the person did not have access to that where they are, then it could be worth considering trying to get access. Yeah.
Thank you. And then from Purvi, do you have any resources that can be provided to young patients for their concerns about their intimacy, sexual life, either partner, as sometimes they are hesitant to talk about this, but struggling and afraid to ask? Or
struggling with like who to ask.
Mm-hmm.
Yeah, definitely. I know that there are some resources that are out there. I can maybe try to add 1 or 2 to my PowerPoint before I send it out. But if you kind of look on the internet, I know that there are some, but I don't have one kind of off the top of my head. I know each center may have their own resource developed too. Like at Toronto Rehab, we have a pamphlet on intimacy after stroke that we'll kind of share with patients and go through it. But online, there are a number of resources as well. And I'm not sure if we're going to I think we are having a talk about this later in the series as well. So also do stay tuned if you can.
Thank you for that, Michaela, because I was just going to say that down, I'm not exactly sure which session it is, but within one of our 9, we do have a special webinar specifically on this topic. So I'm hoping there'll be resources then. So
definitely. Okay. I'm so glad to hear that.
And then there is limited inpatient and outpatient therapy that's covered by OHIP for young stroke patients, and they need to attend private clinics and community to continue once they're done with their OHIP coverage. As they are not working or they don't have private insurance benefits, and if not financially strong, what are the resources available that their therapy sessions could be supported?
I know this is, definitely something that I see a lot in my practice too, that we're saying that the recovery potential is for a full year, but yet often people will only qualify for, a set number of weeks of inpatient, a set number of weeks of outpatient therapy. And then we just don't have in our health system the resources to have, prolonged therapy. And that's where then private therapy comes into play. So if for my patients who just really can't afford to kind of pay out of pocket, then often it is really looking at the resources that were provided by their clinicians to date. And I find that the clinicians that I've seen and worked with and interacted with are really great at providing, home exercise programs when even in the gap between inpatient and outpatient and after finishing outpatient. So it can sometimes be a matter of asking them to bring in the binder that they had or, their home exercise program and look at it with them and then try to problem solve any issues if they were finding that they weren't able to do something in the exercise program for some reason, then we try to problem solve that. But it's really just encouraging them to just try to kind of continue on their own as much as possible.
Eileen, just before asking the next question, I did notice that a hand went up with the participants. So the hand has subsequently gone down. If someone does want to raise their hand and ask their questions verbally, please go ahead and I can, and I see that Rhonda has raised her hand. So I'm going to allow Rhonda to ask her question, and then Eileen, we can come back to the written questions. Is that okay?
Yes, I noticed that one hand too, and I was looking for it. So yes, go ahead, Rhonda.
It was more of a comment that the sexuality session is our last session in this series, and it will be on January the 12th from 12 till 1. So it is the last session in this series.
Thanks, Rhonda.
Thank you, Rhonda.
And I think once we ask the next written question, I can go back. There's another hand raised in the participants. So go ahead, Eileen, and then I'll come back.
Great. And this is a question from Lauren. Is the prognosis for caregiver health specific for caregivers for people who suffered a stroke specifically?
Okay. I'm just trying to make sure I understand the question. Thank you, Lauren. Like the information that I talked about today was specific to caregivers of stroke patients. Like when we talked about that their health is also at risk of deterioration, and so that was relating to stroke patients specifically.
And I know that there's a fair amount of evidence that we have available that does show the wellness of the care partner can make a big difference to the successful outcomes of the person with stroke. And that's why it is so important that those care partners are also looked after and continue to stay well themselves.
Yes, so true, Eileen. Thank you.
All right. Was there another raised hand there, staff?
Yeah, I'm going to turn it to Paula Jane. Paula Jane, you're on mute right now. Okay, maybe we can circle back with Paula Jane in just a minute. I know there's still a couple of questions and only a few minutes to go. So Eileen,
from Elizabeth, who's with the March of Dimes. She's just sharing that they run the After Stroke program. And as part of that program, there are several options that could be considered. There is young stroke survivor groups. There's Ask an Expert that can cover specific topics on intimacy. And they actually have a session in November. And she's put the link there for people who are interested.
Thank you. That's great.
And from Christine, if expats intend to return to Canada for rehab, they should check their OHIP eligibility. She has experienced a 3-month blockage on return to Canada.
Okay, yeah.
Oh, and Christine was one of the people with the raised hand, so.
Okay.
Okay, and then Lauren said, or just caregivers in general. Well, I would say the wellness of caregivers and care partners, whether stroke specific or not, so much of that person's outcome success would be dependent on how well that caregiver is. So I think that will hold across.
Definitely.
All right, Paula Jean says no other question, thanks. Well,
Okay.
great. I think that takes us to the end of the Q&As, and I can see that we're slowly running out of time. So Tina, I'm going
Yes.
to turn it back to you.
Okay, thank you. And maybe Dr. McIntyre, if you stop sharing your screen, thank you. And I will just put up here some so we can see the upcoming sessions. And I want to thank you again very much, Dr. McIntyre, for this fantastic presentation, and also to the audience for all of their participation. And you will see in your inbox that there you've received an evaluation link. And again, please consider filling it out. It's really very valuable for us as we go ahead and plan. These are the remaining sessions that we have in our series. And so as Dr. McIntyre alluded to, there are a number of these sessions that she just spoke briefly to in terms of returning to work and returning to driving and some psychosocial issues, reintegration. And as Rhonda then reminded us, it is the last session on sexuality. So I'd like to thank everyone again, and we will look forward to seeing you all at the next session on October 18. And have a great afternoon, everyone.
Thank you so much, Dr. McIntyre.
Thank you so much for having me, and thanks everyone for your participation. I had a great time. Bye.
Bye.